All right, so it's 9:35, so I think we're gonna get started here. Thank you very much everyone for attending today, this breakout session on solutions. Our speaker is Dr. Richard Lester. And let me just turn over the slide to you, Dr. Lester. I'm just gonna stop sharing and then you can go ahead and share your screen. Awesome, there we go, thank you. So for everyone here that tuned in watching us, I'm gonna quickly introduce Dr. Lester. So it is truly a privilege, and I'm very grateful for Dr. Lester to be here today. He is the co-founder and executive director of the WelTel International Health Society, chief scientific officer of WelTel Incorporated, the director of the Neglected Global Diseases Initiative, and an assistant professor in the global health in the Division of Infectious Diseases, Department of Medicine at the University of British Columbia. The Dr. Lester completed his research fellowship in HIV in Kenya at the University of Manitoba and the University of Nairobi Collaborative, where he initiated development of an innovative mobile phone health mHealth service that was demonstrated in a landmark trial, WelTel Kenya 1, published in The Lancet, to improve HIV outcomes. Dr. Lester has also received the 2020 Digital Health Canada CHIA Clinical Innovator Award, and he continues to conduct studies internationally in Africa, Canada, and the United States, among others. I can think of nobody better to give this talk today on digital health solutions. His talk is entitled WelTel, Digital Technologies for Healthcare Improvement and Global Health. Dr. Lester, over to you, and thank you very much for being with us here today.
Thank you, Alessandro. It's a real pleasure to be here. I love discussing with medical students. I think you're mostly medical students across the country, and we had the privilege actually of Alessandro doing a little bit of work with us as well on his journey. But I'll go today through hopefully a little bit of time for discussion at the end, but through some of our story with digital health and innovation in global health and where it landed us today. So, the rest of your lineup on this conference looked really interesting. So I hope you've all enjoyed it. So first of all, disclosures. As mentioned, I am a physician, so I work in clinical care. I have a research program in digital health with funding from a number of public and some private agencies, and then as well mentioned the social enterprise involvement with co-founding WelTel International as a nonprofit and WelTel Incorporated as a company as a general social enterprise with funding from various sources, as you can see there. I'll just, first of all, sound check. Is it working? Yeah? Okay, good. On Zoom these days, you need to always make sure. So I got my start really in global health and research in medical school, pre-medical school. I always wanted to do science. I grew up watching MASH and wanted to do medicine. And then I also was interested in global health and Africa. I was just intrigued. So I actually went backpacking before medical school to Africa. I actually found out just after I got back when I got in. And then I was always looking for opportunities to do research and global health. And actually Dr. Frank Plummer, who you see up in the top right of your screen, ended up being a mentor. He was presenting here at BC CDC. And I reached out to him, as many of you reach out to your mentors, and said, hey, I love what you're doing. Can I get involved? And I ended up joining Frank Plummer's very well-known research collaboration in Nairobi, Kenya, looking at describing HIV and looking how commercial sex workers were, some of them resistant to HIV infection and trying to develop vaccine work. Dr. Plummer passed away actually in January last year in Kenya, one of his first trips back. But you'll see an article about him in Maclean's magazine recently. He's really renowned researcher through University of Manitoba, had a huge impact on global health and innovation. And so that's where I got my start. But interestingly, he said, and this is important maybe for all of you, sending you there to ask new questions. They had a huge program of research funded by Gates, but I went there to look at immunology. I was working in the lab, but one of the new questions that really came up was really quite different. At the time, You can see HIV pandemic was highly affecting lower resource settings, such as Africa, the dark bars. This was the HIV pandemic in the early days. But then treatment, life-saving treatment was also starting to scale up. And thankfully, even in the resource limited settings, but the thing that was going on remarkably at the same time was the mobile phone revolution. I got my first mobile phone when I was in medical school. But actually the dark bars again show developing countries, and it actually has a much more massive uptake in developing countries than it did even in developed countries to begin with, because they really leapfrogged from not having phones at all and landlines to going straight to mobile phones. So tremendous opportunity. So we actually looked at the opportunity to say, how can we use mobile phones to improve patient care? People were worried then, as mentioned, HIV treatment was being rolled out, life-saving, but in very resource-limited settings, people were worried about adherence, lack of adherence causing drug resistance. The HIV virus would mutate and cause problems for everybody. Turned out that wasn't true, thankfully. And another colleague did a meta-analysis that adherence in Africa was just as good or better than adherence to medication in North America. But we thought, well, how can we improve that? So we came up with a texting program on the ground to say, how can we reach out to patients directly to improve their support, which would therefore improve their adherence, which would therefore improve their health outcomes and life-saving antiretroviral treatment. International health, wonderful opportunity with mentors again, as you find in your path. Connie Kalem, who's a world-renowned clinical trialist, was in Nairobi at the time from University of Washington. I met another director from the World Health Organization who said, you need to measure viral loads. So he wrote a letter so we could get funded to do viral load testing. And we actually did then a randomized trial, well-designed randomized trial to say, can texting patient support improve antiretroviral adherence and health outcomes? And then because I had all this great mentorship, we did things really well, registered the trial. And ultimately, it was the first trial of its kind using texting with patients globally to show improved health outcomes. And we published that in the Lancet as editor's choice in 2010 after I returned back to BC. And I can just go on how through a I'll actually come back to this, just so you know that it is important to do research, because AI, and there's a lot of interest in AI now too, and I think it's great, digital health is great, but it doesn't all work. We have to be careful where medicine is founded in in science, and there's a lot of used car type sales saying, hey, this idea can work, but we really need to test and validate those. So here was a large study recently funded to using a decision support tool to improve maternal child health using an app. It actually increased the odds of neonatal death, because you can say, well, how can that happen? But it might be that you're using technology in a way that actually detracts from the normal patient care. So it's just a note of caution that evidence is important in digital health, as it is with other interventions in healthcare. So good ideas still need to be tested. And this is our program of research through the years. It expanded from that first Kenya trial, other conditions, HIV, TB, maternal child health, asthma. We're actually doing mental health and hospital discharge now. And we've been doing randomized trials and then evolving into implementation science, and as you'll see shortly, a lot of data science as well. And I wrote an editorial or comment in the New England a few years ago about this, how to text, because just texting, it's not just whether you text patients, of course, it's how you text. It's not whether you give patient an antibiotic to treat the infection, you have to give them the right antibiotic. So we've done a lot of research on the best ways of texting, the best ways of doing information. And we came up with this, we called it Ask, Don't Tell, which is basically reaching out to patients by text, asking them how they're doing. They do a little self-check, then they reply, and you connect them through open language to care. And that's what we found through our research has really benefited patients. They like it, and they also get improved health outcomes. And then, of course, equity is a huge one, not only in global health, certainly in global health. And we looked at the HIV pandemic, as we mentioned, really hit some of the most vulnerable populations worldwide. But even here in Canada, many remote communities have less access to care. Also, even within, our big centers, Toronto, Vancouver, Saskatoon, there's marginalized populations, even though they're living maybe next to the hospital, reaching can be difficult. So we've always found the reason we did texting isn't because texting is magic. It's because it has the easiest, greatest reach to people. And of course, we're expanding our work around that. But at the end of the day, we're trying to meet people where they are today with our technology. We can still do a lot of fancy AI and other things, but more important than that right now is we're providing a value service that reaches people. And we found both in gender in our studies that we actually reached women disproportionately more than men in our HIV studies in Africa, which was opposite of what some people had worried about. And then also in Vancouver, in a similar study for vulnerable groups in Vancouver, found that we were able to improve viral load and suppression even among people who use injection drugs in Vancouver. So the other thing is interventions, developing a research program. It's really multifaceted. You really don't look at a single study, and we really found a single study doesn't answer what you need to do. It's really a program of research. You need to answer questions about effectiveness, but also maybe implementation and cost effectiveness and so on. So I had a PhD student a few years ago who helped model some of the cost effectiveness of the change we're causing. And of course, we found, given that it's cell phone use and adherence is highly cost effective, small improvements in medication adherence are probably more profound globally than even coming across a brand new breakthrough drug or vaccine. Just better use of what's there has a major impact and is very cost effective. So we're able to look at some of that. And then the other thing I found, because we thought research, when we did this original research, and I'm going to keep an eye on the time. I don't have my timer here, so please be free to let me know, but that research itself doesn't always reach where you want. There's different ways to contribute to innovation. You can contribute knowledge and knowledge translation, and that's what a lot of core academic research does. But what we found is we had an article published in high impact journal in the Lancet. We got presented informed guidelines at the World Health Organization. Yet at the same time, we weren't seeing this innovation getting out there. And that's because there's a big gap between that knowledge and action, and you still need a way to deliver it. Drugs, just because you show a drug works or a vaccine works, doesn't mean everybody's going to get it. You still need manufacturing and supply chain distribution and everything else. So, and we were finding we weren't seeing the digital technologies that were emerging out there. We're actually following the evidence very well. So we formed, and that's we formed WelTel first as a nonprofit, then as a company because of the structures of funding in Canada and how to do that. So we call it social enterprise, to start to build the technology ourselves, informed by our research, but as a model to be able to scale it and deliver it to places so that they can use the service itself. So that was WelTel. Our first study we named WelTel, and then the company and social enterprise and product have taken from that name. And Dr. Gabrielle Serafini is actually my wife and business partner, and has really led the development of that social enterprise. So really the basis of what WelTel is doing in our approach is this complex model that you see here. And I got this from one of our business analysts and developer people in our lab, Raymond Chow. This was a cancer care model, but it can really be applied to anything. Patients have a tremendously complex system during their patient care. They've got the hospital, they've got their various clinics, they've got labs, they've got diagnostic sites, they go on vacation, they might get sick when they're there. All of this they've got to navigate, and we're trying to make that better for them for good reason. But one opportunity is, instead of just fixing the whole system, can we actually navigate through it and improve the continuity as it is? And the one thing you'll say, we note that in the patient's journey, the one thing that follows them all the way through that journey, no matter where they are, is their mobile phone. So if we have a system that can support them throughout that journey, we don't just need to fix the system, we can also support them and provide that care. And that's really the premise of WelTel, is using a digital support through their mobile phones, no matter where they are, basically keeping it as a hub. And that also means you have consolidated data, which is important for the informatics, important for patient care, and also potential database for quality improvement, novel quality improvement projects. WelTel we adapted for, as I mentioned, started in HIV and other conditions. When COVID hit in January 28, 2020, well, before that, but that was the day I went for lunch from the office at VGH here, and I thought, well, how are patients going to be supported if they're asked to home isolate for 2 weeks? That can be very hard and complicated for people with a lot of questions. So we quickly adapted WelTel, because it's all template based, to be able to do daily check-ins for 2 weeks for home isolation, asking them basically, do you have any new symptoms or do you have any questions? And then they could text back and forth, and it could provide a hub, for a very efficient hub for patients to get supported during the COVID pandemic. And here was an article where they mentioned sort of WelTel and some of the top 10 digital solutions for COVID response early on. And then Johns Hopkins, funded by the Gates Foundation, did another review of digital solutions for COVID, which you can look at, and we were included in that. But essentially, there was 2 ways that we thought we can help the COVID-19 pandemic using this platform. One is to support public health. As I just mentioned, we're asking patients who might have COVID to stay home if they're not sick enough to be, and they've got to home isolate, but we want to monitor them. Phones is 1940s technology, like the actual phoning, very slow, very time consuming. You can miss people, you phone them at the wrong time. If I get a phone call right now, I'm not going to answer it. If I get a text, I can respond later. Texting, by the way, as you know, past phone calls in 2014 in Canada and globally became, before 2014, phoning was still the most popular way of talking to each other. After 2014, it's been texting and texting ever since, and various forms of texting. So we said, okay, we can support patients at home, because if they have better home isolation, they're less likely to break the rules, go out, because they're, figure out how to go for groceries, etc. And that means we're going to decrease the epidemiologic R0, or the transmission, because people are better supported at home. And the place that took this up most quickly for us was actually, there's a news link there. You can see a bit of how it worked, but the Rwanda government, who was already using it for HIV programs there, adopted it quickly last year, and they've had a really positive response. And we got some CIHR funding with various collaborators, including in Toronto. Some of you may know Carmen Logi is an expert in stigma, because we want to be able to look at open language. Can we actually detect how stigma is influencing patient care and home isolation? And then Dr. Giuseppe Caronini, who leads one of the data science natural language processing programs here at UBC, as well as some of our international collaborators. The other way we thought we could support the pandemic is just virtual care. And I think most of you know now, when your medical path is going to be very different than the pre-COVID medical path, much more integrated virtual care across the board. Now, we were already working in this space for years, patient engagement, enhanced our program to do, now you can do video consults, you can schedule your clinic, but you can still do that texting engagement. Patients can send photographs, you can do wound care management remotely. And so the other way of supporting the pandemic is, because people couldn't actually access their doctors and clinics and hospitals as well, is through patient care. So we put both these public health and patient care models together through the platform. And you can see in Rwanda, they adopted this nationally very quickly, within a couple of weeks. We were very, they act fast. They know how to handle pandemics. They were next door to countries with Ebola outbreaks recently, just prior. So they adopted WelTel in their national program very quickly, and enrolling a country of 12 million people. And they did quite a good job early on with technology all around supporting their response. And I'll show you how they've actually done well. A good example of the virtual care model of just looking after vulnerable patients at home was BC Children's Hospital Cardiology Transplant had been doing it already in a study prior to COVID. But you can see what happened when the COVID pandemic hit. Suddenly, a vast majority of their patients escalated very quickly to doing virtual care through the platform. texting, phone, video, etc., to stay safe at home, because often they're immune suppressed and vulnerable in other ways. But there's another element that's become quite exciting about quality improvement and what we can do with this data. So the fundamental concept of our WelTel in digital health was just improving patient care through communication. Continuity of care, instead of just booking clinic visits, you can actually now follow and support your patients more longitudinally. You develop better relationships. But listening, we know from medical diagnosis that actually the history you take of your patient is 95% of the work. You know, the lab tests and other things, those are all important and confirmatory, but listening really gives you the vast majority of the information you need. And that goes from a quality improvement point of view too. If we can listen to what our patients are asking us about in that continuity of care, not just when they're in the clinical office, maybe we can learn some things from that, some novel things to improve healthcare. So this is where partnering with our data science group at the university, and we've got some Michael Smith Foundation innovation to commercialization funding, was to say, can we actually evaluate the conversations using, instead of a PhD student spending 6 months manually categorizing all these conversations for a paper, can we do this automatically using modern computing tools? So using natural language processing, which basically takes conversational data sets, you can look at topics, you can look at sentiment. This bar in the middle is actually talking about whether the conversation was more positive or more negative. Can we actually better understand from patients' own voices? And especially because we're asking using this ask, don't tell, how are you model, we're really letting patients tell us what's important to them, and we can analyze that for quality improvement. And furthermore, we found that just the patterns of texting, we call it metadata around their texting pattern, we could actually predict someone's health outcome a year in advance, looking at some of our previous trial databases. So the texting pattern was able to predict whether someone had a suppressed or unsuppressed viral load at the end of the trial. And that could be quite useful because you don't necessarily want to wait a year to find out somebody's failed treatment. If you can find ways through through analytics to find out warning signs earlier, we may be able to intervene earlier, do some counseling or whatever is required to improve that path so that people ultimately have better outcomes. And then mentioned again, just some of the digital technologies. This was a colleague published early in the pandemic on some of the adoption of digital technologies for the COVID pandemic. But I'm just going to say a couple of key points for my view, pandemic control, evidence base, and we tend to really use it for vaccines, for drugs, but it tends to get bypassed in digital health space where people just go straight to big corporations and say, oh, they can do it because they've done something else, or they go straight to, hey, this sounds like a good idea, even though it's not validated, not based on science. So I think in Canada, unfortunately, and in BC, we've really missed the boat a lot on some of the digital virtual care that where other countries like Korea and Rwanda and others have really nailed it and done well in their COVID response. But the other, so evidence-based, you need to know it. Reach is important. You can't just reach the highest, best patients. It's actually those patients that are the most vulnerable that actually take up most of our time, and they're the ones that change the dial on our health outcomes. So we really need to make sure we're reaching the people who need it most. And if that might not mean using the fanciest technology, it might be using the basic, most simple technologies, but it's about making sure you reach the people who it's really going to matter most. But you've got to deploy fast too. And in pandemics, you can't have systems that take months to organize and approve. You've got to act fast, and some countries have done that well. And then we've got to keep evaluating, of course, so we keep learning from all of these experiences and data. I'll say innovation, wins, but trust is the other thing. And this is where we provided a relationship-based to home-based care. Rwanda, for instance, tried some other things like putting GPS bracelets on patients to detect if they left their home for the pandemic. That didn't work very well. That sort of punitive approach has some potential options, but it also, you can erode trust. And as soon as you start to do punitive approaches, you can erode trust, and therefore you get less people overall following, public health and other recommendations. So it's not simple. It requires a lot of thought, a lot of testing, a lot of understanding. but really trying to win sort of a relationship-based approach we've determined can win. And then this was the COVID Performance Index. Again, we were very thrilled to be working with Rwanda. We're now working with New Zealand a bit, ranked in the top 10 in their country responses to Rwanda. Unfortunately, Canada's a little bit lower down. We're finally kind of getting out of the woods, but I think, and there's some things Canada's done, I think, very well. But you know, innovation is a path we want to really start to make sure we're post-COVID pandemic, we're a lot more nimble, I think, and able to use some of these things. All of this work requires a tremendous amount of partnerships. So as you go, you're going to find partners, various different types, community partnerships, government, non-government, private, perhaps. And then I will hopefully have some time, but say thanks again. It's an honor talking to medical students. I think most of you are, and including those of you who aren't. And I'd be happy to take any questions if that's part of the program. But thank you very much.
Thank you very much, Dr. Lester. That was a great presentation.
And I'm, oh, sorry, I had my sound off. Hopefully I wasn't missing anything there.
No. Everything went well. We're just going to wait for some questions to kind of roll in the chat. But in the meantime, would you be able to maybe comment or talk about some of the applications of WelTel kind of in Children's Hospital, which I know that you guys have been working on, and also maybe in like to home at VGH and that sort of stuff as well?
Sure. So BC Children's Hospital adopted the program. So pediatric transplant patients, heart transplant patients, were having a real challenge when they go from pediatric care, where they've got a parent often, they've got a very good multidisciplinary program that supports them. But then as they transitioned to adults, they were actually losing some patients because they were no longer having the same level of support, and they would maybe not take their transplant immunosuppressive medications and actually reject an organ. Of course, your body rejecting a heart organ transplant has serious consequences. So they reached out and were looking for ways to better support patients through that continuity. So Dr. Catherine Armstrong is really spearheaded that program. She's a cardiologist there. And what they did is, so they started, they know that many of their youth like texting. In fact, sometimes a patient comes into the office, sits in front of you, maybe with their parent or on their own. You have a discussion. And then they found after they leave, they text in the question they really wanted to ask, because they're more comfortable texting than asking the question in person. So they found that this was quite valuable in providing that meet patients where they're at. So we introduced WelTel into that environment where patients enroll via their phone. They get a weekly or so text message asking them how they're doing. The way WelTel works is it's got a dashboard. So you see all the incoming messages. You can access it from your mobile phone or from the desktop. Different team members can log in. So the doctor, the nurses, pharmacist, counselor, etc., can log in and follow and respond to patients as need be. And then you can also now, of course, we expanded because of COVID. You can you can escalate to phone them, or video, or you can schedule video appointments and so on as well. So they've been using that. As I mentioned, the usage went up, and really it's just a way to balance virtual care, but not just virtual care as in like Zoom and other like this. That's just purely a modality. But now they're using it really as a way to follow patients in a more streamlined way, and that's the example in pediatric cardiology. It's also being used in a similar way in Haida Gwaii. A remote primary care doctor up on off the coast is using it to look after patients who have difficulty accessing care.
Awesome, thank you very much. We have some questions in the chat now. Shada asked you, is there any area of health you'd like to test WelTel next?
Very nice question. And we've really taken this approach because we focus on the patient rather than the disease. It's really meant and therefore we use open language. It's really meant we've been able to apply WelTel without changing it, without using any programmers, simply by setting up the configuration. for a wide range of diseases and conditions, as you said. So we started with HIV. We worked in maternal child health, helping women through pregnancy. I mentioned we worked in tuberculosis care, where they require higher monitoring. Now we're starting to go in primary care. Mental health is one of those areas where we really feel, and it's cross-cutting, in fact. Like when we say we're going to work in mental health, we really always have. You can imagine the HIV cohort that we were supporting in Kenya in the first days. Quite a lot of the support that they required that led to better medication adherence was actually around mental health issues and otherwise. And we've worked with some First Nations projects here and some addictions management. So I really think, and one of our most recent funded programs is to do patients who were discharged from the inpatient psychiatry unit at the Siegel Center here in Vancouver General. We're going to be looking at 30-day readmission as our to hospital as a primary outcome. But we're really trying to look now to see if we focus on the mental health more specifically, how can we improve health outcomes that way? So that's, I think, one of the next big areas.
Thank you very much for that answer. Now, Brian asked, are there any issues with mobile phone use in countries that have expensive internet or poor internet connection in rural areas?
Yeah, so thanks. Another great question. This comes back to reach and using the modality. Your choice of modality for us has always been whatever reaches the most people. And there's two ways we've really addressed that. That's the reason we use basic texting. You can actually, in northern Kenya, where they have only 2G internet, and many people still have basic Nokia phones, we're actually able to work in almost any environment because we just send basic text messages. How are you? They can reply they're okay. And even at the healthcare provider can enroll a patient using a text command. They can, so if you have the internet, of course, I think I showed you some of the dashboard. You can do all the fancy things. If you don't have internet, you simply enroll and follow patients by basic texting. But even beyond that, the other thing is the innovation isn't always just in the technology, it's the social part. So we enable patients to enroll by proxy. So for instance, you might have a family or community member who has a phone, and they can actually, you can still enroll other family members who don't have a phone or who have a language barrier into the program, and you simply work through a proxy, and that's really extended the reach even further.
Awesome, thank you very much. Sorry, I'm just going a bit faster because there's some questions that kind of rolled in, and I want to make sure that everyone, we get to all these great questions. And so the next question is, Rodrigo asked, what safeguards are there to threats to cybersecurity and confidentiality of data being shared virtually?
Another great question. So data security is one thing, and privacy is yet another thing. So data security there's a lot of standards, and we've had to, and of course, do meet and hopefully even lead in some of these standards. So for instance, Canada has rules about data residency. So we're hosted on cloud that's all within Canada for Canada. In Rwanda, we ended up going from the cloud into their national data centers. But there's an encryption, auditing, a whole bunch of standards that need to be met on the security side. But equally, or perhaps even more important, is privacy. And how do you manage? And one of the reasons, in fact, you can imagine our very, very first study in Kenya for HIV, at that time, there was still a tremendous amount, and there still is, of stigma in HIV. So the privacy could even mean to someone being sent away from their family. People were actually even killed sometimes at that time for finding out their status and other things. So privacy was really important. The way we dealt with that is we had patients involved in our design from the beginning. And we used the term simply, how are you, or Mambo. So we never sent out personal health information or anything that indicated your status. Now, if a patient then responds and say, oh, I'm fine, what's my CD4, what's my viral load? Now they have control over that, right? And they've made that decision. So one of the ways we've really led in maintaining privacy is through again, the way that we text and provide information and monitor. And we've never had a accidental breach of privacy in the programs sort of around the world from that point of view. But it's a good question. And it's also one of the tensions with innovations, because a lot of innovation, the biggest barrier to get through can be trying to manage privacy standards. So it's a good question.
Awesome, thank you. David, I see your question. I'm just going to ask Rodrigo's second question just to follow up on his first one. So Rodrigo asked, in African countries with more political instability, such as not Rwanda, Kenya, or Ethiopia, where telecommunication towers can be in high-risk environments, do you see WelTel still being a viable solution to providing virtual healthcare?
Another great question, and I love those last mile types questions because they're extremely important to us. So the reality is, no, we can't get everywhere. If a place doesn't have cellular service, of course, we can't do it. But interestingly, but if you look at the global map for like just basic cellular network access, not internet. So cellular access is over 90%, 95% in Africa. Internet access is still only around 50% or so. So if you're using apps and that, you're going to miss a huge part of the vulnerable population. But if you use texting, you really extend your reach, but it's still not perfect. But we work in, for instance, in northern Kenya, which borders the Somalia border and has a lot of insecurity. Very remote places, we work, they have some of the highest child mortality rates as well because of the remoteness. But people know exactly which mountain and which rock to stand on to go hold their phone up and get those text messages. They can do their banking by the text messages. They find out, where to sell their cows through those. So health just becomes part of that, and it's been one of our considerations and drivers. But we really find you were never satisfied, even if you reach 90% of people. The right question to ask is, what about the other 10%? And in that's where we've looked at some of, I said, the social innovation as well. So you might only have one person in the village with a phone and has to walk a day and then do it, but he or she might be able to represent somebody else in that village. So we just try our best, but it's the right question to ask.
Great, thank you very much. The next question we have is from David. He says, great presentation, Dr. Lester. Do you see BC adopting a provincial-wide telemedicine program similar to the Ontario Telemedicine Network?
Another great question, and I'm going to say something that's maybe a little controversial in this, is yes, probably, but I also think there's a lot of risk in having monolithic programs, and they tend to use a lot of resources, be very slow, and essentially you end up in a potential monopoly situations where if innovation really gets stifled when you have single monolithic systems, because the program, and this is why there's in business, this is why there's monopoly laws and so on in places, so that because you need competition to drive innovation. Even if you get the best adopted wide program in 2021, in 2026, it might not be best anymore, and the motivation for others to be there. So I actually favor an open system where you have security standards, privacy standards, of course, you need them, interoperability and data sharing standards. Of course, we want to be able to share data, but the actual applications, and one of my favorite recent quotes of Bill Gates before his recent scandals, was his biggest regret was actually for Microsoft was not adopting this free app-based market the way Google and Apple did. And actually Google and Apple ended up passing Microsoft because of it. Microsoft thought they could build everything they needed to build for people. And Google and Apple said, we can't build the best running app. We can't build the best, all the financial apps. You need a lot of healthy competition out there. So they created this sort of app market. And I think personally, the way telemedicine and all our digital health innovation in Canada should go, if we want to stay leaders in the future, is actually having an open competitive market where people get to choose, but they meet those critical standards of data security and data sharing that are required for best patient care. That's my approach, but I'm happy to debate. Yeah.
Awesome. Thank you very much for your answer. So Sophie from Waterloo asked or said, thank you for your presentation. What challenges have there been working remotely and or with clinicians, researchers, patients in different countries?
Sorry, was that challenges? I missed the quick.
Yeah, what challenges have there been working remotely and or with clinicians and researchers, patients in different countries?
Great. So there's Of course, a lot of successes, a lot of challenges. I highly recommend anyone who's going to work internationally. It's one of the most rewarding things you can do is work with others in different scenarios, help address some of those challenges together. And first of all, to identify challenges, the first thing is identifying the challenges before finding a solution. And you only do that by being really out there and talking to other people. So for instance, this is where a lot of innovation comes from. A challenge, for instance, I mentioned some of the policy challenges. Sometimes there's better or faster, more flexible bureaucracies around processes to get approvals and privacy and that sort of thing. Those are all major challenges in this space. The others are, working remotely through the pandemic. Because of Zoom and other things, we're working in Rwanda and Kenya. We have regular meetings. It's actually gone fairly well, that part, supporting and being able to do that. But I personally still miss, you don't quite get the same level of in-depth feeling and understanding as you do in person. So hopefully we'll find some balance between those things. But yeah, the challenges are many, but the solutions are even more. So if you have specific ones, I'd be happy to discuss those too.
Great, thank you very much. Our next question is from Tony from U of T. He says, thank you for the presentation, Dr. Lester. I know you've talked about the ask, don't tell with SMS. I'm curious if you could expand on lessons learned when communicating via SMS.
Thank you. Yeah, very much so. And we've done a lot of research on frequency of messaging, content of messaging, types of messaging. There's meta-analysis on one-way texting versus two-way texting. Should you text information? Should you text motivational messaging and so on? The greatest lesson we've learned, which was actually validated through research, but we found out just by talking to patients from day one, was the ask, don't tell. The power of that is a fewfold. Number one, it doesn't get much more patient-centered than someone asking you, how are you? And they're asking, how's your diabetes, or how are you taking your medication? They're asking, how are you? And that gives you the sense that someone cares. And we've done a lot of research. Patients feel cared for when you ask you, how are you? Because you're focused actually on the person as a whole, but it has other advantages. What it does is it triggers a self-check. If I ask you, how are you? You've got to respond. Before you respond, you have to think, well, how am I? If I've got asthma, am I sleeping at night? If I've got heart failure, are my legs swelling up? Or am I just depressed or stressed or whatever? And then it allows you to be a patient-centered point of view. But the other thing is, by using open language is far, far more powerful than having defined. Now, we like working with structured data because it's easier to analyze. So for instance, if I say, here's a 10 symptoms from COVID, tick the box of which ones you have, versus just saying, tell me about your symptoms. It's easier to analyze the latter, but the other one's more powerful perhaps in that you get to get new information and more patient-centered information. So because of modern analytics and computing, we have a lot more power to analyze open language, and the ask, don't tell really allows you, one is make it patient-centered, two, you don't restrict the type of answer, so you can get novel information, and then we're getting better at analyzing that. So those are some of the lessons, at least. And texting is just a modality, whether you do it by text, SMS, WhatsApp, or video chat or whatever, it's really, that's just the modality. It's more important in how you communicate than what mode you communicate through.
Great. Thank you very much for that answer. So there aren't any more questions, so I'll just take the opportunity to ask one last question, and that is, what advice do you have for, I guess, young graduates or healthcare professionals who are hoping to kind of use virtual health or digital health in their kind of future practices or careers? Is there any specific advice you'd like to give them, or any kind of tips or anything like that?
Sure. I mean, it's an exciting time. So in some ways, there can be a low barrier to entry into digital solutions, because many of you use technologies. I actually started this without I'm not a programmer, computer programmer. So you can just ask the right questions. It's medical students and care providers and administrators and public health specialists, you have the advantage of, you know, the domain, you know, the content, you know, the problems. The technology, wonderful thing about it is it can almost always do what you want it to. The more difficult thing is finding out what you actually should do and what's important to do. So that's where you're really, that's where you're in your career is gonna lead, hopefully, as you enter into this, is asking the right questions and then trying to guide the right solutions, and then partnering with the technology. You can, so many of you might be programmers and you can do some of it yourself, or you're going to partner with people who can. That would be one. The other is just mentorship. Reach out to experts around. You know, the major advantage I had in Nairobi was actually there was such a collaboration of international experts from University of Washington, University of San Francisco, University of Manitoba, Belgium, all over, and you could find the best clinical trial expert to give you some advice on your clinical trial, the best engineer, computer engineer, etc. So really the other is just reaching out to mentors who you think can guide you for the specific areas you want help.
Great, thank you very much. We actually have one last question, if that's okay with you. Rodrigo asked, or he's curious whether there's any work by WelTel being done in West Africa or not.
Not yet. Would love to. We have some partners in the Gambia that we had considered. I've traveled to West Africa, not yet. Feel free to reach out if you've got an idea. Yeah.
And I guess on that note, would you be okay with us providing the participant with your email address if they have any other questions or anything like that?
Sure. Yeah.
Okay, great. I can pass that along to everyone. Okay, I don't see any more questions in the chat, so I guess I'll just take this opportunity to thank everyone for coming, and thank you to all the participants, and thank you, of course, Dr. Lester, for being here and for answering all our questions and the presentation. It was very, very helpful and valuable. Thank you very much.
Thank you all. Okay, take care. Good luck.
Thank you. Thank you. Bye-bye.